Very good morning to everybody here. Wonderful, great thought, and thank you very much, Brand Shaper, for your generous introduction. At the outset, I'd like to extend my thanks to Banshi and his team for giving me this opportunity to be here amongst you today morning, share my views regarding initiation and intensification of therapy when it comes to management of type 2 diabetes in day-to-day clinical practice. My previous three speakers have alluded to the necessities, the requirement of insulin for control of hyperglycemia in patients with type 2 diabetes as well as type 1 diabetes. The responsibility on my shoulders is to inform you about the initiation and once initiated, how to intensify in the pursuit of a good glycemic control. Why is it necessary to initiate insulin? We all know that vast majority of diabetic patients in India are managed by general practitioners and family physicians. In the setting where the up to the mark facilities for healthcare facilities are not available in Indian subcontinent. We have several guidelines which guide us regarding management of type 2 diabetes with oral anti-diabetic drugs given by international institutions and organizations. But as on date, we do not have a consensus statement or a definite guideline which should guide us regarding the principles of management of diabetes on the basis of initiation and intensification of insulin in Indian subcontinent, which are specifically meant for general practitioners. What people with type 1 diabetes have been doing as a part of self-education program is calculating the dose-enabled doses, the diet-associated adjustment of insulin doses which is in practice patients with type 1 diabetes. In a situation where 4 out of every 10 persons in India suffering for diabetes are getting treated either with insulin or insulin and OHA alone, it is very relevant for us to understand the principles of initiation and intensification of diabetic therapy. We have had reference from Dr. Praveen just now saying that basal insulin is considered as a golden standard by most of the practicing physicians in initiating insulin therapy. But there are several areas wherein these basal insulins are not sufficient enough to control the glycemic status. And we are required to take help of premix analogs, or premix insulins, or even basal in addition to basal short-acting insulins to cover the postprandial excursions. Why do we really need to initiate insulin and intensify? The process of insulin initiation and intensification in type 2 diabetes is in the pursuit of acquiring very good. But it must be achieved at the cost of patient safety, minimizing risk of hypoglycemia, weight gain, and minimizing the prick burden. There are several methods to initiate and intensify, like start with basal insulin, basal plus, and then basal bolus. And of late now, we have also given preference to initiation with GLP analogs. Premix insulin actually helps the person with type 2 diabetes to manage their blood sugar levels, but instead of taking multiple pricks, patient can just be comfortable with taking 2 pricks. And these 2 pricks are able to give him a good glycemic control with bare minimum frequency of injections. And the choice of premix insulins available, it depends upon the availability of the resources and the financial status of the patient. Premix insulins actually contain a short-acting insulin which is able to avoid delayed postprandial hypoglycemia. That's the usual features most of the time observed in individuals. And depending upon the dietary composition of the patient, whether it's a high carbohydrate or low carbohydrate, you are able to titrate the doses of short-acting component in premix insulin to perfectly neutralize the postprandial excursion. So that leverage you can always have. So to begin, we have various modalities to initiate insulin therapy in patients, like once daily insulin, premix insulin, or a co-formulation basal insulin. Usually commence with a small dose of 60 units per day before a major meal. And there are several studies which have tested the administration of insulin either before a small or a large meal, but it doesn't in long term doesn't significantly alter the glycemic status or HbA1c in patients for a long time. But it has been traditionally suggested and accepted to give major insulin doses before a major meal. To attain the glycemic targets, insulin therapy can be started with a smaller dose. I have told you, if presenting A1C is less than 8, we go with smaller doses of 6 to 8 units of basal insulin. And within 3 months, if the patient doesn't hit target, then we have got leverage to add either short-acting components of insulin, either pre-meals, and that should be considering breakfast, lunch, or dinner as one of the meals in order to have a good control over of the fasting and postprandial excursion of the glycemia. We we have various preparations. The analog insulins can be administered with food, before food or after food, because they are ultra fast acting. As against the conventional premix insulins, you have to administer minimum 15 minutes before the scheduled meeting. Whenever patient after 3 months of this oral initiation of basal insulin is unable to reach to target, we may be required to switch to what is called as a twice daily or co-formulation premix medication. While intensifying from OD to BID regime, it is recommended to increase the total dose by 10% and split the dose into 60% at the breakfast and 40% at the dinner. So when BID initiation is contemplated in insulin naive patients, it's always better, preferably for individuals with HbA1c of more than 8, it is recommended to start at 12 to 16 units. While it is higher doses if the glycemic status of the patient is broadly deranged, and divide it into 60% at the breakfast level and 40% at the dinner level. And the titration, well, we have to titrate the doses of the insulin also. The titration depends very much upon the pre-dinner blood sugar levels. If the pre-dinner blood sugar levels are high, then we have to intensify doses of pre-breakfast insulin. If the fasting blood sugar levels are high, we have to intensify the pre-dinner level of insulin. So that's how you go on titrating or adjusting the doses of insulin in the pursuit of fasting or postprandial hyperglycemia. If inadvertently, if you are facing a problem of hypoglycemia in such patients, you find that the patient goes for severe hypoglycemia late in the evening or early morning, we are required to cut short the doses of insulin by nearly 20%, and the target is, if you are presenting fasting blood sugar levels goes to less than 70, you are immediately advised to reduce the doses by 20%. There are situations wherein people do not do very well with twice daily doses of insulin, premix insulin, wherein you are tempted to switch on to what is called as a TID regime, conventionally tried in a therapy in a trial called 1, 2, 3 basal premix insulin regime. This is required because in many a times you find the patient's carbohydrate load is so high that it is difficult to achieve the postprandial blood sugar levels of near normalcy. In such a situation, time comes when you are required to initiate 4 to 6 units of short-acting insulin pre-lunch so that you are able to have a post-lunch normal glycemic status. In such a situation, it would be advisable to reduce your pre-breakfast levels by almost 20% so that you don't end up landing that patient into severe spells of hypoglycemia in the evening. So the suggestion is that whenever TID premix is considered, it is recommended to switch over to 50-50 composition rather than going in for 30-70, which is a conventional preparation. Normally, we use 30-70 as a 30 as a short acting component and 70 as a delayed acting component. But whenever we are contemplating therapy twice a day, then perhaps it would be logical and advisable to switch over to 50-50 preparation of insulins. The recommended targets are again the pre-meal target of 80 to 130 milligrams, that is what is your desired goal. Breakfast insulin doses are increased if your pre-lunch doses are pre-lunch sugars are high, and pre-dinner sugars, if they are high, then you are supposed to increase your pre-lunch blood insulin doses. And if the fasting blood sugars are high, you are required to accelerate or intensify the pre-dinner dose. So that's how you have got, distinct average. The only hassle here is that you would be required to do blood sugar levels repeatedly to ensure that whatever dose is selected is given precisely according to the necessity of the patient. So it's a simple algorithm which tells us about how to initiate. For two groups of individuals with glycated hemoglobin less than 8 and more than 8, for less than 8, we initiated once daily therapy. start with 8 units of basal insulin, and in individuals with A1C of more than 8, you start with twice daily doses of insulin, starting with 12 to 16 units of premixed insulin. And if the patient is not up to target after 3 months, then you go on up titrating the doses or intensifying the therapy. In basal, if the patient is inadequately controlled with basal insulin alone, you start giving him breakfast dose adjustments for attaining post-breakfast levels of less than 140. And if the patient is not getting control with BID doses, you intensify further with adding one more dose of insulin pre-lunch. And everything is done very calculatively just to have a perfect postprandial control of the blood sugar levels. This algorithm is very simple, and this has been discussed, and it's a synopsis of whatever we have discussed earlier about it. So having learned about this, let us have a prototype case, because that would help us understand how to administer, how to start, and how to intensify therapy in a patient of type 2 diabetes. What rationale do we have for combining basal and bolus insulin and single injection? Dr. Bridgmore has very nicely told about the utility of basal plus and basal bolus injections, multiple injections, subcutaneous injections for the control of diabetes. Many times it's not hassle-free. Patients are not accepting multiple pricks. So therefore, we are compelled to minimize the number of pricks in a patient of type 2 diabetes, and to achieve that, we use these co-formulations of premix analogs. So let's have a prototype case. By the way, there is a simple question which I would like to toss up to the audience, like how long does it usually take from diagnosis to starting insulin in your day-to-day clinical practice? How long do you require? May it be 1 to 3 years, 3 to 6 years, 6 to 9 years, or more than 9 years?
It depends on the blood sugar, sir.
Yes, it depends upon the blood sugar, but how long does inertia of the general physician prevents him from initiating insulin? So it's pretty long. It's pretty long before we are motivated, geared up, or psychologically, sort of arming ourselves sufficiently to start insulin. So it's pretty long duration of time. So he's a prototype patient, a 50-year-old Kamala working in bank for 6 years history of diabetes, complaining of burning pain and numbness of feet, diagnosed as hypothyroid also for 3 months before. And she's on multiple OHs like sitagliptin 50 milligrams twice daily, metformin, glyphosate, and levothyroxine. BMI is 31, pretty high. A1C is 10.8, absolutely fat. Fasting 262, BP 340, weight 81 kilograms. An examination also revealed she has got diabetic retinopathy and macular edema. Obviously, the diagnosis is centered around type 2 diabetes, diabetic neuropathy, diabetic retinopathy, non-proliferative, and hypothyroidism. Such a patient comes to us as a therapeutic challenge, treatment challenge in day-to-day clinical practice. What options do we have now? In the wake of retinopathy.
Yeah, again,
So
now
let
we
us come
do
to
have
treatment options.
combination of diclofenac and lansas also. Works too.
Okay, let us see what are the options started. We have various options like starting premix insulin, starting with basal insulin, starting with co-formulation, or some other options. Now, what was done to this patient was sitagliptin and metformin among the OHA were discontinued. Sitagliptin and metformin were continued, but sulfonylureas were discontinued. Levothyroxine, of course, was continued. Laser photocoagulation was done to take care of macular edema and retinopathy. She was initiated with premix analogs, 20 units with the breakfast, which was considered as a major meal by the patient. And these 20 units were gradually titrated over 28 weeks over 4 weeks. At the end of 4 weeks, the patient's blood sugar status fasting was 130, pre-lunch was 140 milligrams. Still not perfectly at target. At the end of 4 weeks, additional 4 units were added at dinner time, and these 4 units were further titrated to 8 units after a gap of 4 weeks. So at the end of 8 weeks, the treatment with co-formulation was 28 units before breakfast and 8 units before dinner. What this has done to the patient? Patient eventually had returning of the parameters to these levels of fasting 104, pre-lunch 106, and pre-dinner 124. Perhaps a state of perfect hypoglycemia. So at the end of 12 weeks, glycated hemoglobin decreased from 10.8 to 7.1 with no history of hypoglycemia. Home glucose monitoring showed that she had significant improvement. Vision also improved. Patient feels more energetic and regain interest in the weight. So what has virtually transformed this patient's glycemic status as well as clinical status is initiating with co-formulation, intensifying and adding from OD to BID doses and following this patient's meticulously for a period of 3 months. So what we find, couple of minutes more, madam, please. What we find at the time of initiation, the deranged parameter which patient had of very high fasting, postprandial blood sugar levels and elevated glycated hemoglobin. Weight was 81 that time. They had significantly improved over a period of span of 12 weeks, and we had fasting of 103, postprandial of 108, A1C returning to practically 7.1 with bare minimum 2 kgs of weight gain, which perhaps on good education patient could take care of it by taking recourse to some exercise or dietetic schedule. So initiation with co-formulation had a superior efficacy, significantly causes reduction in the glycated hemoglobin with lesser rates of hypoglycemia and offers significant control of fasting and postprandial parameters, which is always a very difficult proposition when patient is on basal insulin therapy. So this is about how do we initiate insulin, how do we intensify insulin, how do we monitor these patients in day-to-day clinical practice. So to summarize, friends, I would say insulin offers maximum efficacy undoubtedly in management of diabetes mellitus in the patients who are not up to target in the pursuit of reduction of the long-term complications. We have novel co-formulations with distinct fasting and postprandial glucose lowering effects. Initially could be started with OD doses which have to be accelerated or intensified to BD doses, and they do very well with BD doses, usually are not required to add BID. IDA gas or co-formulation, premix co-formulation BID represents a simple alternative to basal bolus. The number of pricks would be reduced from 4 to 2 with a good attainment of fasting postprandial characters as well as attainment of the glycemic status, and patient can be comfortable and walk back home happy with a good glycemic status. So this is the normal practicing trend we are encouraged to acquire and get used to while treating our patients in diabetes with diabetes mellitus in the pursuit of excellence in diabetes care. With that, I conclude. Thank you very much, gentlemen.